Good morning, good day, good evening. My name is Fransiska Malfait. I'm a clinical geneticist and I work in the Center for Medical Genetics at the Ghent University Hospital in Ghent in Belgium. And I'm also the Chief Scientific Officer for the Ehlers-Danlos Society. And today I will talk a little bit about the challenge of living with a rare disease from my perspective, at least as a clinical geneticist. So first of all, a rare disease. What is a rare disease? In the United States, a rare disease is defined as any disease, illness, or condition that is affecting fewer than 200,000 people. In Europe, it is defined as any disease, illness, or condition affecting less than 1 in 2,000 citizens. So this means that about 1 in 10 individuals in the USA and in Europe are living with a rare disease. This means about 30 million Americans and 30 million Europeans are living with a rare disease. And this is about 6 to 10% of the world population. There are about 6,000 to 8,000 rare diseases, and each year about 250 new rare diseases are identified. 95% of these diseases do not have an FDA-approved treatment. About 80% of the rare diseases are genetic. 65% have serious and debilitating clinical manifestations. 50% of people living with a rare disease are children, and about 30% of children with rare disease will not live to see their 5th birthday. And so about 1 in 5 people personally know a patient suffering from a rare disease. So I think this puts the word rare into the right context. Some facts about rare diseases. Some rare diseases start in childhood, others start in adulthood. Some rare diseases are visible, others are not. Many rare diseases are complex with multisystemic involvement, resulting in a wide variety of healthcare needs. And many rare diseases such as EDS are chronic and sometimes life-threatening. So here you can see all the different organs and systems that can be involved in the different types of Ehlers-Danlos syndrome. People can be dealing with ophthalmological problems, musculoskeletal problems, skin abnormalities, vascular problems, cardiac problems, craniofacial abnormalities, gastrointestinal problems, genitourinary problems, and many other symptoms and signs. So these are really very complex and multisystemic disorders. Not only do these rare diseases have a physical impact on the affected individual, they also have practical, emotional, psychosocial, and financial impact on the individual, but also on the whole family. Usually, receiving a diagnosis for a rare disease is a complex and long endeavor. In general, it takes about 7.6 years for the average patient to get diagnosed with a rare disease in the USA. And some studies have shown for EDS that this odyssey even is a lot longer. On average, it takes about 8 physicians to get the proper diagnosis. The average patient receives 2 or 3 misdiagnoses before being properly diagnosed. And only about 45% of patients have all their costs covered by insurance providers. And less than 50% of patients suspected for the disease receive a satisfactory molecular diagnosis. So rare disease misdiagnosis and the diagnostic odyssey takes a great toll on patients' physical, emotional, and economical health. So for Ehlers-Danlos syndrome, the diagnosis may be suspected or by many different healthcare providers, such as pediatricians, rheumatologists, physiotherapists, cardiologists, cardiac surgeons, orthopedic surgeons, dermatologists, general practitioners, pulmonologists, etc. But sometimes even none of these specialists actually suspect that the diagnosis is EDS, and it's the patient or the caregiver themselves that have to try to find a diagnosis, and often via Dr. Google. So some of the hurdles during this odyssey, we have already talked about the multiple misdiagnosis, but for instance, in children with a classical type of EDS or with a vascular type of EDS, where there is a lot of bruising and scarring, for instance, there can be a suspicion of child abuse. And for people having lots of problems that are not put together in the right context, these people are often inaccurately branded as having psychological problems, but there are many other hurdles along the way. So it really takes a clever doctor to put all these pieces together, or a clever patient maybe. And some people are actually never diagnosed, and hence for them it is very difficult to find the right treatment or the right management. When looking for a molecular diagnosis of a rare disease, and here particular for EDS, this is also not an easy task. At present, there are 14 different clinical subtypes of EDS, but there are already 20 genes that are involved in the pathogenesis of the Ehlers-Danlos syndrome. And we know that not all genes have been discovered. And so with time, we are quite sure that additional genes will be identified for EDS. So already this is a complex start. When we do molecular analysis for these rare diseases in the lab, we use the next generation sequencing technologies. I'm not going to go into detail how this works, but in general, there are three possibilities that the lab uses. The first one is whole genome sequencing, the second one is whole exome sequencing, and the third one is targeted gene panel sequencing. So let me just give a little bit of background about our genome and our DNA so that you can understand these different techniques. For those of you who have heard the previous talk on mutations and variants on unknown significance that I gave earlier this day, I explained that in our genome, only about 2% of our genome codes for proteins. And so these 2%, these are called the genes. And we also refer to this as our exome. The other 98% is junk DNA and does not code for the proteins. And actually, we don't exactly know very well the function and, of this junk DNA. So when we do whole exome sequencing, we will sequence all of our genome. And you could compare this to a whole orange. The whole genome is the whole orange. But we can also extract the 2% of the protein encoding part of our genome, which is then this slice of the orange, and this is called the whole exome. So we extract actually the 21,000 protein encoding genes from our genome, and we only look at those. What we can also do is do a targeted gene panel analysis. This means that from this exome, we filter out only the genes that are associated with a certain disease. For instance, the 20 genes that are associated with EDS. So this is then targeted gene panel analysis. It is very important to know for people who are starting on this adventure of finding a molecular diagnosis for EDS, that even doing whole genome, whole exome, or targeted gene panel analysis, it is possible that we will not find a molecular defect. As I have explained, we have probably not identified all genes that are associated with EDS. And of course, for instance, hypermobile EDS is a very good example for this. So it is really possible that even going at length through all the possibilities of genetic testing, that no molecular diagnosis can be made. On the other hand, there is also a possibility that through the genetic analysis, we identify a variant of uncertain significance, and we actually don't know what this variant means to the health of this person. So variant of unknown or uncertain significance is a variant form of a gene that is identified through genetic testing, but whose significance to the function or health of the person or an organism is not known. So your doctor actually does not know what this means. As I have explained this morning, when the lab finds a variant of unknown significance, it is possible that we will have to continue with additional studies trying to understand the meaning of this VUS. And I think this can include doing family studies, trying to see whether a child has inherited the variant of unknown significance from a family member, for instance, or we can do skin biopsies in order to look at the protein or do electron microscopy and look at the organization of collagen in skin. There are some urine analysis that can be done for certain types of Ehlers-Danlos syndrome. But for some variants of uncertain significance, there are no functional studies, or we never find the right answer whether it is pathogenic or not. So this can be associated with a lot of uncertainty and frustration for the patient, but also for the physician. Another thing that is of importance when doing molecular testing, especially in case of whole exome sequencing and whole genome sequencing, is the possibility of identifying secondary or incidental findings. Secondary or incidental findings are genetic variants that are unrelated to the original reason the genetic testing was ordered. For instance, identifying a pathogenic variant or a mutation in the BRCA1 gene or BRCA1 gene, which is associated with an increased risk for hereditary breast and ovarian cancer when performing whole exome sequencing for a suspicion of EDS. It is very important that a patient or a family is aware of this possibility when starting the process of whole exome sequencing, and it has to be talked through with the genetic counselor or with the geneticist whether or not the person wants to hear about these secondary or incidental findings. Otherwise, they may come as a big surprise. So it is very important that there is good pre- and post-test genetic counseling when doing molecular analysis. First of all, with regards to the expectations, as I have explained, gene panel analysis, whole exome sequencing, and even whole genome sequencing do not always allow to identify the molecular defect, and this can be associated with a lot of frustration. And it is also very important that patients and families starting this process understand the complexity of the genetic analysis and of understanding the genetic results. What is the difference between pathogenic variants versus variants of unknown significance? What is the meaning of primary findings, but also of possible secondary findings or incidental findings? Also, when something or nothing is found, explaining these results to family members and other people around can be very challenging for affected individuals. Once a diagnosis is molecularly confirmed or not, when a clinical diagnosis is withheld, receiving this diagnosis or this label is not the same as actually receiving help. First of all, there is no FDA-approved treatments for any of the EDS types. EDSs are, all the types of EDS are multisystemic diseases, as I have shown, and so different areas of the healthcare system may be called for. However, expertise in all these different areas is usually or very often not available nearby, or not even within one's own country. And people have to find this expertise sometimes over the borders of their own country. Often, affected individual, parents, or caregivers of affected individuals feel they are left with the responsibility of figuring out the next steps once a diagnosis is made. And this is often associated with a sense of isolation, and this can also lead to anxiety, depression, and sometimes also exhaustion. After a diagnosis of a rare disease is made, there often is a period of adjustment. First of all, emotional adjustment, and this is also associated with seeking knowledge. And it is clear that patients, parents, caregivers want tangible information about the disorder that has been diagnosed, but also about relevant support systems that are available within their own community and how to access them. However, common experiences and needs of patients and caregivers with rare diseases are that there is a lack of provision of information at the time of diagnosis by the healthcare provider. There are barriers in accessing specific services, and there is a poor care coordination by the healthcare provider. And as a result, patients or caregivers often become expert patients or expert caregivers. Often they have more expertise in their diagnosis than the actual healthcare provider. And this can lead to strained relationships with their healthcare provider, which in turn can negatively impact the care. It has also been shown in studies that patients and caregivers often take on the role of a care coordinator in order to improve care continuity and communication between the healthcare providers. So recognizing and validating the role of expert patients or expert caregivers must be central to the care provision. And actually, genetic counselors are very well positioned to advocate for and facilitate relations and communication between affected families and healthcare providers. So what we see in rare diseases in general, and also in the field of EDS and HSD, is that patients and caregivers become more actively involved in promoting their own care and the interests of others affected with the same disorder. Patient and family involvement in advocacy and research transforms the distribution of power between the so-called experts and the so-called lay people, which contributes to the development of new modes of care delivery. And this then in turn can affect clinical decision-making, policy development, and research related to advancing rare disease care. So this highlights the importance of peer support and collective advocacy. And so patient organizations such as the EDS Society, but also local organizations, they provide opportunities to form social connections, either in live conferences, but also through social media, through helplines or talking or discussion groups, etc. They also provide the opportunity to attend informational meetings, to develop educational resources, to support research, and to do advocacy. And so one of the buzzwords within this context is patient empowerment, also referred to as patient participation. So the World Health Organization defines patients' empowerment as a process through which people gain greater control over decisions and actions affecting their health. The European Patients Forum defines it as a process that helps people gain control over their own lives and increases their capacity to act on issues that they themselves define as important. And so patient empowerment is both an individual process and a community process. And how can patients actually be empowered? Well, first of all, through health literacy, and health literacy is defined as the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. And here, the importance of patients' organizations can also not be highlighted enough. So they also help in educating physicians and patients and in capacity building by uniting all these people with rare diseases. They can have a stronger voice also in the clinical decision making and in policy making. Secondly, shared decision making. Shared decision making is a process by which a clinician and a patient jointly make a health decision after discussing options, potential benefits and harms, and considering the patient's values and preferences. And thirdly, patients can be empowered by supporting self-care and self-management, which refers to the ability of a patient to deal with all that a chronic illness entails, including symptoms, treatment, physical and social consequences, and lifestyle changes. And to be effective, it needs to rely on a coordinated approach and proactive engagement of physicians, patients, caregivers, and healthcare organizations. So there are already a few organizations that are trying to ameliorate the life of people living with rare diseases. And I'm giving just one example from Europe. Here are the European reference networks. European reference networks are virtual networks involving healthcare providers across Europe. They aim to facilitate discussion on complex and rare diseases and conditions that require highly specialized treatment and concentrated knowledge and resources. And for EDS, there are two European reference networks that are of relevance. So the first one is ERN RECONNECT, which is the network for rare and complex connective tissue and musculoskeletal diseases. And you can see the link to the website for RECONNECT. And the second one is VASCERN, which is the network for rare vascular diseases, where vascular Ehlers-Danlos syndrome is covered. And you can also see the link to VASCERN. And for people in Europe, I recommend you to have a look at these networks, because there is a lot of information available there. And then obviously it is very clear also that the EDS Society is very active in patient empowerment and trying to facilitate the communication between healthcare providers and patients living with EDS and HSD. And so, for instance, it provides information through websites, through meetings, through webinars. It also provides support through virtual support groups, through the EDS helpline, through online communities. There is an EDS newsletter and an e-magazine called Loose Connections. It is very active in educating both healthcare providers and patients through the EDS ECHO program. It is also active in helping research in EDS and in HSD with research grants for clinical and basic sciences and also micro grants. And there is also a very strong interaction between the EDS Society and the International Consortium on the Ehlers-Danlos syndrome and related disorders, facilitating this communication between the patients and the specialists and the scientists and the researchers. So with this, I would like to thank you for your attention and would be happy to take any questions. Thank you.